All right, welcome guys. Thank you. If we can have all those folks in the back find their seat. Got delinquent Dr. Connors there finally coming back to work. Good to have you back, Jeff. I know you're jealous of me doing the intro in your old role. Welcome to Grand Rounds. It is our pleasure today to have the third installment of the Chief Resident Grand Rounds. And I just want to start by saying thank you to all the chief residents. The Grand Rounds done by chiefs are oftentimes the highlight of the Grand Rounds series. This year did not disappoint. We know that this is a ton of work to put these together, to give these presentations in front of this crowd, and you guys crushed it. So thank you for that. And the new chiefs that are in the crowd, you've got big shoes to fill. So hopefully just keep these in mind as examples. Go get your CME through the code there. And then let's go ahead and present. We've got 3 presenters today. This is going to be a very good hot topic, talking about a drug that we just talked about not long ago, and social media. So I think this is going to be a terrific Grand Rounds today. Vineet sends his apologies. He's on his route to SGIM and can't be here, but he says thank you, and he'll be watching online. So the first speaker we have is Dr. Rosenberg. She's from California originally, attended UC Berkeley for undergrad, then Cornell for medical school, and then came and joined us here at CU doing med peds, and has stayed on as a chief resident. And next year she'll be going on and doing a toxicology fellowship here. We're very thrilled to be able to keep her here on this campus. Dr. Thielen from North Carolina originally, went to Elon University where she played basketball. She went to UNC for medical school, then came here for residency and obviously chief year, and then is staying on here with us in cardiology. So again, very excited to have you here. And Dr. Zehr, originally from Indiana, went to Indiana University for undergrad, IU for medical school, and then here for residency as well. And unfortunately, he will be leaving us. He's going to Vanderbilt for pulmonary critical care. And today, I think we're starting with Dr. Rosenberg. And welcome, and take it away.
All righty. Thank you so much for having us at Grand Rounds. As Dr. Stenya mentioned, I'm Lynne Rosenberg. We've got Sam Thielen over there in the blue and Evan Zehr in the seat up there. And today we are going to be talking about the impact of direct-to-consumer advertising in the digital age as told through #Ozempic. We have no disclosures to report. So we'll jump right in. I want everybody to think back to the last time they were in clinic. For some of you, this may have been a long time ago, so think hard. But you're coming into a busy day and you're smart. You came in early to do some inbox task management. You open up your inbox to a message from a patient you've cared for many years. Hi, doc. I saw an ad for Ozempic during the Nuggets game the other day. Go Murray. Or if it was last night, go Jokic, am I right? Woo! And think I have a few friends on it. Would you prescribe this for me? Thanks. You respond by saying you'd be happy to talk about this at the upcoming annual wellness visit next week. By show of hands, who has had a patient come in and ask for medication by name? Most people in the room. Now, what if I told you that the countries highlighted here in red are the only countries in the world that allow direct-to-consumer advertising for prescription drugs? You might think, how in the world did we get here? And we're wondering the same thing. So by the end of today's talk, we hope that you will be able to identify the various historical and policy-related pressures that led to the unique development of direct-to-consumer advertising within the United States, explore how direct-to-consumer advertising impacts multiple areas of society and healthcare delivery using the quadruple aim model, and understand how recent expansion of direct-to-consumer advertising in the digital age presents both unprecedented challenges and opportunities for advocacy and patient education. Now, a quick note that through the rest of this presentation, you'll hear us refer to direct-to-consumer advertising a couple different ways, DTCA, DTC, just plain advertising, but we are always talking about direct-to-consumer advertising. So with that, we'll start with a history lesson. We'll go back in time to 1708 when Nicholas Boone ran the first ever advertisement for a medicine in an American newspaper. This image here is the same ad that ran in London for Elixir Salutis, but as you can see, it's described as a secret far beyond any medicament yet known. Turns out it was a laxative, so the description checks out. But this ad sparked the beginning of advertisements in magazines for years to come. Turlington's Balsam of Life was advertised for kidney and bladder stones, colic, and inward weakness. And it has many ingredients, the main one of which is also the main ingredient in marshmallows. So no wonder it helps with inward weakness. Gaudry's Cordial, a very sweet syrup, was advertised to soothe teething infants. This was opium. So these advertisements continued for over 2 centuries until the 1930s. Sulfanilamide was a sulfa drug that came in a tablet and powder form. To try and compete with other sulfa drugs on the market, the chemists at Massengill wanted to make a liquid form for children and found that it dissolved well in diethylene glycol with a delicious raspberry flavor. Given there were no regulations on safety studies at the time, they shipped out over 630 bottles nationwide. Within a month, multiple deaths were reported to the FDA, and Massengill had to do a full recall. The founder of the pharma company put out a statement saying, "My chemists and I deeply regret the fatal results, but there was no error in the manufacture of the product." You know what? Massengill was right. They hadn't broken any laws. In fact, the only thing they were charged with was misbranding for calling this an elixir instead of a solution, since an elixir implies it contains alcohol. The FDA commissioner at the time pointed out how the inadequacy of the law had contributed to this disaster. He stated, "This incident emphasizes how essential it is to public welfare that the distribution of highly potent drugs should be controlled by an adequate federal food and drug law." Thus, the 1938 Federal Food, Drug, and Cosmetic Act was born. Under the new drug section, added to prevent such tragedies, the FDA was given authority over labeling of drugs. However, control over drug advertising remained with the Federal Trade Commission, or the FTC. Fast forward 20 plus years, Dr. Frances Kelsey was an FDA physician responsible for applications to market new drugs. Within her first month, an application for thalidomide, a medication for morning sickness, landed on her desk. This drug was already widely distributed in Canada and Europe, so the pharma company expected a pretty quick turnaround. The astute Dr. Kelsey rejected the application, describing it as an interesting collection of meaningless pseudoscientific jargon apparently intended to impress chemically unsophisticated readers, holding off on approval until they could show studies detailing toxicity and safety during pregnancy. Reps from the pharma company were livid. Dr. Kelsey held firm long enough for reports to start to emerge elsewhere in 1961 about severe birth defects and phocomelia occurring in children born to mothers who used thalidomide. After this near disaster, JFK enacted the Kefauver-Harris Amendments to the Food, Drug, and Cosmetic Act in 1962. These changes essentially pushed for further consumer protection, requiring manufacturers to provide proof of effectiveness and safety of their drugs before approval by the FDA, and actually transferred the authority of advertising from the FTC to the FDA, who took a more proactive approach in ad regulation. They required drug advertisements to disclose fairly balanced and accurate information of side effects, contraindications, and effectiveness. So, up until this point, while there was some advertising toward consumers, most of it was still directed toward physicians in medical journals. In 1981, a 23-year-old woman named Liz Munch, who previously worked in TV advertising, interviewed for a job at Boots Pharmaceuticals. She asked the company president to describe the company's main customers, and he replied that it was doctors. She famously replied, "Why isn't it the consumer?" 2 years later, Boots ran the first ever commercial for a drug on TV, as seen here. Many companies after that point began shifting their advertising strategies toward consumers for the years to come. Over the next 2 decades, the FDA faced significant pressure from pharma companies regarding their regulations. They argued that the brief summary of contraindications, side effects, and effectiveness often required them to produce multiple additional pages at considerable expense without providing added value for the consumer. They also stated that providing detailed summaries via electronic media was unrealistic in 10, 30, or even 60 seconds. So in 1997, the FDA issued a draft proposal for new guidelines on broadcast DTC advertising. For the first time, manufacturers could give both the drug's name and condition without disclosing all the risks. However, advertisers were required to mention the most important risks and to provide a statement explaining that additional information was available elsewhere. Now, this Modernization Act was a game changer. It significantly relaxed prior regulation of DTC advertising from those Kefauver-Harris amendments, as you no longer had to list all the risks as long as the information was accessible somewhere. These relaxed restrictions meant advertising became a whole lot more accessible to companies. Since the Modernization Act, DTC marketing rose from $700 million in ad spending in 1996 to $5.4 billion in 2006, a nearly 800% increase. So what else happened in the US in 1997? Raise your hand if you know what this is. Nobody. Wow, nobody knew in any of our practices either. But in the first ever social media site, 6 Degrees, launched in 1997. So began a booming new use of technology as multiple social media sites began to launch. As you can see, in 2007 and 2008, these sites rapidly became the most visited sites in the world. Now, as we move forward in time on our direct-to-consumer timeline, you can imagine that the advent of social media really changed the world of advertising, and the FDA was forced to play catch-up. In 2014, the FDA released its first draft guidance for drug advertising on social media platforms, stating that if a company makes a benefit claim, they must also include the risks and direct access to more information. But it's not always the company making the claims, is it? Some of the folks making claims about drugs online are just people who have used the medicine, had a family member use it, or just read about it. They are by no means experts in the risks and benefits of these medications, but have no regulations on their statements. To address this, the FDA also drafted guidance on correcting third-party misinformation. They state that it may benefit the public for firms to correct misinformation if possible, but they can't require these companies to do so. Further, if these companies do correct misinformation, they aren't required to satisfy the other regulatory guidance as long as they're truthful. So for example, they can list a number of benefits without listing any risks. As this draft guidance went into circulation, providers were beginning to feel the pressures of the increase in DTCA by pharma companies. In 2015, the AMA issued a statement arguing direct-to-consumer advertising may raise awareness about diseases and treatment and may help inform patients about the availability of new diagnostic tests, drugs, treatment, and devices. However, direct-to-consumer advertising also carries the risk of creating unrealistic expectations for patients and conflicts of interest for physicians, adversely affecting patients' health and safety and compromising patient-physician relationships. The AMA urged providers to remain objective, avoid bias, resist pressures to prescribe, and report false advertising. Most recently, in 2023, the FDA turned their draft guidance into a final rule regarding DTC advertising. The gist of their guidance is in the title. They require ads to be presented in a clear, conspicuous, and neutral manner. That brings us to today. Living in a country in which direct-to-consumer advertising is legal, online platforms are growing rapidly, and the FDA is trying to keep up with the ever-growing world of social media. Today, we'll walk you through a case study to highlight what the interaction of these two overlapping timelines actually looks like, and how this overlap has led to new and unprecedented challenges for healthcare. We chose to discuss Ozempic today because it's an exaggerated example of what is happening in provider offices all over the country, and one that many of you have become familiar with. Now, we couldn't talk about this today without acknowledging a few important things about why there's been such a craze around Ozempic. First of all, there have been weight loss campaigns for many decades, as seen here in this ad for Lucky Strike cigarettes. So in some ways, the advertising of GLP-1s for weight loss is not new. Further, our society has extremely complicated notions and stigma surrounding weight and beauty standards. So perhaps the Ozempic craze is just seen as the next step in the search for the pharmaceutical holy grail. Finally, GLP-1s are clearly extremely effective medications. As you can see in this graph, folks have an average weight loss of about 20% of their body weight. So while these are among the many reasons that GLP-1s are particularly popular, we want to hone in on the way these drugs have been advertised and how that has changed over the years. So we'll first describe the most classic type of advertising, direct-to-consumer advertising. Novo Nordisk is the pharmaceutical company responsible for the production of Ozempic. They advertise directly using print, TV, radio, billboards, internet. Here's an example of a classic direct-to-consumer ad that many of you may be familiar with.
Type 2 diabetes?
Discover the Ozempic Trizone. With my Ozempic Trizone, I lowered my A1C, CV risk, and lost some weight.
In studies, the majority of people reached an A1C under 7 and maintained it. Ozempic lowers the risk of major cardiovascular events, such as stroke, heart attack, or death in adults also with known heart disease. And you may lose weight. Adults lost up to 14 pounds.
Catchy tune, hard to forget. The next way these drugs are being advertised is through secondary markets, but also via print, TV, radio, billboards, internet. Now, to be clear, this does not happen through Novo Nordisk. So who are these secondary markets? Well, here are two examples. On the left is an ad for Ro, a secondary pharmacy that prescribes GLP-1s directly to patients after only a short telehealth visit. On the right is a photo of the Weight Watchers GLP-1 house. Weight Watchers purchased an online pharmacy and created this house to promote their new endeavor by inviting influencers to come and take photos with their oversized injectable pens. Reminder that neither of these companies have relationships with Novo Nordisk, but are advertising the medication for their own benefit. Which brings us to our final type of advertising, third-party advertising. This describes non-medical professionals, mostly on the internet, talking about Ozempic. Here's an example of a comedian going as the Ozempic skeleton for Halloween after using the drug for a number of months. Here's another example of a TikTok influencer showing off how she gives herself her Ozempic injections. Now, we can't know for certain whether or not these people are being paid at all by Novo Nordisk, but oftentimes they are discussing these topics on their own. And theoretically, if they are being paid, they should be indicating that in their post. This is a musical artist who created a parody song about the recent craze. I'd be remiss not to play a clip of it for you.
Compound pharmacy, my doc won't fill the script for me. ABC, 1, 2, 3, GLPs for you and me. Keep up with the Kardashians. I want to be so super thin. I used to want an hourglass, but now I'm starving out my ass. Just appetite. And when they ask, I'll say I'm eating right. Ozempic with Govi.
Now, as silly as this is, it is absolutely free and unregulated advertising for all of these medications and is a way that younger generations are being advertised to daily. So, how do we think about the impact of direct-to-consumer advertising and social media on our healthcare system? Well, we want to present you with a lens through which we will view how DTCA is affecting different aspects of our world. In 2008, Don Berwick and colleagues introduced the triple aim into the healthcare lexicon, which was later expanded to a quadruple aim. This is an approach to optimizing health system performance and consists of 4 pillars: improving the health of populations, enhancing the patient experience of care, reducing the per capita cost of healthcare, and improving the work life of healthcare clinicians and staff. For the next portion of today's talk, I'm going to hand it over to Sam to look at the impact of direct-to-consumer advertising in the digital age through the lens of the quadruple aim of improving healthcare. Thank you.
Okay, am I on? Great. Thank you, Lynn. Let's jump back into our case that we introduced at the beginning. You're pre-charting and you see that your patient needs a lot today. She's due for a pap smear, she needs vaccines, she needs diabetes screening, you want to have a discussion on weight loss, and you need to address her hypertension. Her blood pressure was 165/91 when she checked in today. Your mind is juggling all these things and you walk into your patient room. The first thing she says is, "Hey, will you prescribe this for me?" And she hands you her phone and proceeds to play that commercial that we all just watched. And she's so excited. With that in mind, let's talk about the patient experience as it relates to advertisements. We'll use this framework to discuss how advertising impacts both patient behavior and perceptions of their healthcare experience. First of all, we know that patients seek additional health-related information in response to advertisements. Based on a variety of survey data, 11 to 43% of patients seek additional information in response to these ads. This can be information related to a new symptom, a new condition, and can sometimes lead to a new diagnosis. They seek this information from the internet, from friends and family, and sometimes from their doctors. Most of the time, patients discuss advertisements with their providers at visits that are already scheduled for other purposes, but 2 to 11% of the time, patients state that advertising was the sole reason for their visit. In addition to seeking more medical information, we also know that patients request medications in response to advertisements. Studies show that 7 to 33% of patients have asked their provider for a prescription in response to an advertisement. We also know that this occurs in a dose-response relationship. So the more patients are exposed to advertisements, the more likely they are to request medication of their provider. We'll discuss the physician response to these requests in our next section. So let's talk about adherence. Overall, the majority of data shows that there's an increase in adherence in response to advertisements. However, it is a little bit mixed. In surveys, 18 to 26% of patients report an increased adherence in response to advertisements, meaning that they see a commercial and it reminds them to take the medication that they're already prescribed. In an example of a study that showed increased adherence, this was one that looked at 180,000 children on Medicaid with a diagnosis of asthma. They compared advertising spending of asthma medications with medications claims data for asthma prescriptions. And what they found is that as advertising spending increased, so did the prescription claims for the asthma medications, likely due to an increase in adherence. They also went on to show an important clinical outcome that as advertising spending increased, there were decreased rates of asthma-related ER visits for these children with asthma, also presumably mediated through increased adherence. However, like I mentioned, the data is a little bit mixed. So this study actually showed reduced adherence in response to advertisements. They studied a population that has known rates of high rates of non-adherence, those with serious mental illness, so those with depression, bipolar disorder, and schizophrenia. They showed that patients who reported exposure to advertisements reported a 61% rate of non-adherence compared to only 26% of those who reported no exposure to advertisement. So a pretty stark difference. The patients that reported non-adherence said that it was because they saw the commercial and saw the side effects listed in the commercial and then got worried about the medications that they were taking. So they just stopped them. Notably, the majority of these patients didn't consult with their provider before stopping the medication. Overall, we know that advertisements impact adherence, and it may vary based on which population you're looking at. So not only does advertising impact patient behavior, it also impacts patient perception of their healthcare delivery. Patients feel empowered in response to advertisements. They like coming to their doctor armed with knowledge and thoughtful questions. In one large phone survey, over half of patients reported they liked seeing advertisements. Another third said that it helped them make better healthcare decisions. In another study, a third of respondents said that advertisements helped them feel more informed. Others say that it made them feel positive about the health benefits they were perceiving from these advertisements. And still others said that it made them feel a greater sense of control. In the same positive theme, patients also perceive a positive impact on their relationship with their doctor based on advertisements. In fact, 34 to 62% report an improved relationship and perceive this benefit. They state that advertisements help them have better discussions with their physicians, which contributes to this positive perception. So now that we've reviewed the patient experience of how it interacts with advertisements, we see that advertisements can cause patients to seek more information, request medications, potentially increase their adherence to their currently prescribed medications. They feel more empowered, and they also perceive an improvement in their relationship with their doctor. So back to our case. Your patient sitting in front of you has clearly been responsive to this advertisement, resulting in her asking you for a prescription. Now it's up to you. You quickly think, I don't have time for this today. There's so many other things to do. This is primary care. You can't just brush it off though, because it will damage your relationship with the patient. Does she even know what this is for? The commercial was talking about diabetes, but I think she's interested in this for weight loss. Does she know the side effects? Should I prescribe this? So with that in mind, let's move on and talk about our second aim, the provider experience as it relates to advertisements. You might all feel this first one. Physicians consistently indicate that they feel an increased pressure to prescribe in response to requests from patients from advertisements. We know that half of surveyed physicians reported feeling at least a little pressure to prescribe. And this not only feels bad, but it can also have consequences. One study showed that 5% of physicians prescribed a medication in response to a request from a patient, when in reality, they thought a different medication would have been better, or they should have recommended lifestyle changes instead. They may have done this for a variety of reasons, maybe to maintain the relationship with the patient, maintain rapport, avoid potential conflict from saying no. And some even hypothesize that this may be due in part to reimbursement models that use patient satisfaction surveys as a metric. So we already discussed that advertisements lead to increased requests from patients, but do physicians actually prescribe in response to these requests? The answer is yes. There's compelling data that show providers often prescribe medications in response to their patients' requests. Several studies show prescribing rates as high as 75%. Now, the degree to which providers prescribe in response to advertisements versus what they would have prescribed anyways is harder to elicit, since a lot of our data is from surveys and not from randomized controlled trials that would include a control arm. One example of this is from a study that collected data during the Super Bowl. Efinaconazole, an antifungal used to treat onychomycosis, was advertised during Super Bowls in 2015 and 2016. We can see here with the arrows that immediately following each Super Bowl, there was a spike in prescriptions, most likely due to these advertisements. We know that ads lead to patient requests, and that patient requests can lead to providers prescribing. In addition to affecting physician behavior, advertisements also affect physicians' perceptions of their patients. Surveys of physicians consistently show that they believe their patients have an incomplete understanding of the medications that they see on advertisements. They say that their patients don't understand the risks, the side effects, limitations, or costs, and that they simultaneously overestimate the benefit. Unfortunately, this may be at least somewhat true. In one study, 43% of patients thought only, quote, completely safe medications were allowed on ads, which we know there's no such thing as a completely safe medication. This goes to show that despite the regulations that Lynne shared with us earlier, we really need additional safeguards around drug advertisements aimed at improving consumer understanding. Increased time. Physicians perceive that advertisements lengthen the duration of their clinical encounters. In fact, 56% of physicians believe this. They state it requires time to correct the misconceptions that are created from advertisements. And while physicians consistently share this perception, including the AMA, to our knowledge, we don't have any objective study that is actually measured to see if there's a true increase in the duration of the clinical encounters based on advertisement conversations. And lastly, physicians perceive a negative impact on their relationship with their patient because of advertising. Notice this is the opposite perception of what patients feel. This negative perception can be due to a variety of reasons. Physicians report that it can be challenging when patients gain a false sense of autonomy based on misinterpreting advertisements. They also state that conflict can arise when they don't prescribe a requested medication. The AMA even states that advertisements undermine the patient-physician relationship, And others believe that the ads create encounters that are more transactional rather than based in trust. So now we've tackled the first two aims of our quadruple aim by investigating how direct-to-consumer advertising impacts both the patient and provider experience. So let's go back to our case. After a discussion with your patient, you realize she does have indications for a GLP-1 agonist. Her BMI is over 30, and she has a weight-related comorbidity, hypertension. So you counsel her on the risks and benefits, and she's really excited to try it. She feels really proud of herself because this medication was her idea in the first place. You pin the order and step out to discuss the plan with your attending. So Evan will now walk us through the rest of our case and the remaining sections of our quadruple aim.
Thank you, Sam. You guys can hear me okay? All right. So you step into your team room now and you staff with your attending. You nail your plan for hypertension and they agree with all the vaccines you want to give your patient. They bring up, though, that this is a third patient this week who specifically asked for a GLP-1 by name. And so you think, is this something that's occurring everywhere? How is direct-to-consumer advertising impacting population health? And so with this, we're going to pivot to the third pillar of our quadruple aim model. Talking about population health, I think it's important to build up another conceptual model. This has three components we're going to walk through today. The first is prevention. Prevention exists on a spectrum. You can have things such as primary prevention that really focuses on preventing a disease from occurring at all, but then other forms of prevention can focus on reducing long-term sequelae and side effects from a chronic disease. Examples of prevention include wearing a seatbelt while driving or getting a flu vaccine during flu season. Next, we're going to talk about promotion. Promotion has overlaps with prevention, but really is about optimizing health for patients regardless of their comorbidities. So examples of this can include exercise and eating a healthy diet. And then finally, we're going to talk about protection. Protection is focusing on keeping people safe as they go about their daily lives. So this can include environmental regulations to limit pollution or post-marketing surveillance to ensure that medications are safe for patients. So now that we have this model, we're going to walk through each of these and see how direct-to-consumer impacts these different areas. There may be some potential benefits we'll talk about or some potential harms. Let's talk about prevention first. This is an example where direct-to-consumer advertising may be beneficial with regards to prevention. So I'm going to first highlight here in red. This is where the Advisory Committee on Immunization Practices made the recommendation that any adult above 65 should get the PCV13 vaccine, which in the United States was Prevnar. You can see here with this blue box that this advertising by Pfizer for Prevnar increased substantially after that, to the right of that right line. So after the recommendation to vaccinate all adults. But how did this impact consumers' information-seeking behavior? For that, we can turn to a Google Trends analysis, which essentially shows how many times are people searching for Prevnar on Google. You can see after the recommendation, there was a significant increase for searches for Prevnar on Google. And so you may be asking yourself, how do we know, is this being driven by the recommendation by the ACIP, or is this being driven more so by Pfizer advertising? It's tough to tease out, and the authors acknowledge this. Still, I think it's very telling that Pfizer significantly increased their advertising budget to the tunes of millions of dollars because they thought this is going to help their bottom line. So this is an example of direct-to-consumer advertising having a positive benefit on prevention, but sometimes these benefits are less clear and there may actually be some harms. For that, we're going to turn to this JAMA article titled Association Between Drug Characteristics and Manufacturer Spending on Direct-to-Consumer Advertising. They considered a variety of drug characteristics, but the most interesting one I want to talk about is that of added clinical benefit. So drugs with high added clinical benefit have clear efficacy, good data, they may be novel or an entirely new drug class. Drugs with low added clinical benefit fail to meet these standards. This article showed that a higher proportion of advertising dollars was spent on direct-to-consumer advertising with drugs with minimal added clinical benefit relative to those with high added benefit. So that means a medication with low added benefit had an advertising campaign largely focused on consumers. Medications with high added clinical benefit had a more diverse advertising campaign. So there was some advertisement certainly towards consumers, but then there was also advertisement towards providers, such as print ads in a medical magazine or sending samples to a provider that they could then give to patients. So we've talked about prevention. Now let's talk about promotion. Sam has already talked about the benefits of educating patients and how direct-to-consumer advertising can do this. So I'm not going to go into a specific example, but education for patients sometimes is harmful. And for that, we're going to turn to this article titled Association Between Direct-to-Consumer Advertising and Testosterone Initiation and Testing in the United States from 2009 to 2013. The authors looked at trends in advertising for testosterone and then examined the impacts of this advertising on testosterone-specific metrics. These metrics can include testing for testosterone levels, initiation of testosterone replacement therapy, or initiation of therapy without testing at all. And so I want to specifically focus on the period before January of 2012. You can see here that all advertising during this time was this low T unbranded advertising. So what is a low T unbranded advertisement? Examples of this included advertisements saying if you are having troubles in either the boardroom or the bedroom, you should talk to your provider about getting testosterone testing. And so these are all kind of educational commercials that didn't actually talk about any specific drug. And during this time frame, they then looked to see what was the impact of this advertising campaign on testosterone-specific metrics. And so the authors found that these low-T educational campaigns were associated with increased initiation of testosterone replacement therapy without any prior testing. So this is an example of education leading to inappropriate patient care. Patients were started on testosterone replacement therapy, incurring potential harms without any clear benefit. And so education, not always beneficial for patients. And then finally, I want to shift and talk about protection. Let's talk about a case study. So rofecoxib, or Vioxx, was approved in 1999. As soon as it was approved, Merck immediately marketed this medication broadly. They spent $160 million in the first year. This was more than Coca-Cola spent advertising Coke that year, and more than Anheuser-Busch spent advertising Budweiser. So huge amounts of money. The same year, we had the release of the Viger trial here on the right. And this showed, among many things, that there was potentially increased risk of harm, specifically myocardial infarctions and other cardiovascular events in patients receiving rofecoxib. This didn't raise to the level of banning rofecoxib, but it did raise some concerns. So this flash forward now to the 2004 approved trial, and you can see now there are clear evidence of harm from rofecoxib. And rofecoxib, I think I forgot to mention, is a selective COX-2 inhibitor. So you can see on the Kaplan-Meier curve on the right, there's a clear separation at 18 months where rofecoxib has increased risk of thrombotic events relative to placebo. These thrombotic events, again, are like heart attacks and strokes. And so because of these findings, rofecoxib was removed from the market. So this is just one example of one medication, but I would argue that direct-to-consumer advertising increases these risks for a variety of different medications for two reasons. First, we need to consider what exact medications are advertised to consumers through DTCA. Then we also need to think when medications are kind of the most risky for patients. So first, we can go to this article, A Decade of Direct-to-Consumer Advertising of Prescription Drugs, to better understand what medications are prescribed to patients. In this article, they looked at the top 20 medications that were advertised to patients in 2005. And of these 20 medications, they saw that 17 of these top 20 advertised medications had a campaign that started within 1 year of drug approval. This is from 2005, but it's a trend that continues today. And that makes sense, right? Pharmaceutical companies have a competitive advantage when a drug is first released. They're the only ones who can market it and profit from it. And so they should advertise heavily in that period to maximize their profits. And then to understand some of the risk of these early drugs, we can turn to this article, which looked at drugs who were approved from 2001 to 2010 and their rates of post-market safety events. So post-market safety events can include a warning or FYI by the FDA, a black box warning by the FDA, or removal of the drug from market. This doesn't happen for every drug, but you can see there's still a substantial amount of drugs that have some kind of safety event, roughly 40% or so. It's important to note as well that most of these safety events usually occur within the first 7 years of a drug being released. The median time to a safety event was a little bit over 4 years. So this is concerning, right? You have drugs that are marketed heavily when they're first released. This is also the time when drugs are most likely to have a safety event. And so we have a scenario where we could see a story very similar to the rofecoxib example I walked through earlier. Now that we've talked about population health and walked through these examples, I want to talk about how Ozempic and GLP-1s in general interact with these different aims. Now I would argue that this GLP-1 craze fails to advance these measures. And so first, let's go back to the direct-to-consumer pharmacy that Lynne was talking about. As a reminder, this is a pharmacy that's online. Patients fill out a survey or questionnaire, and then they're connected with the provider either via a telephone visit or a virtual health visit, and then they get prescribed a GLP-1. Many have raised concerns about this. There was a recent New England Journal of Medicine article, opinion piece, that questioned some of these direct-to-consumer platforms. There is various concerns. One of them is that pharmacies just aren't following these patients as closely as would a primary care provider who's seeing this patient in person. You can imagine a patient who has pulmonary hypertension gets started on one of these medications, they have poor PO intake, they get shifted off their Starling curve, and they have a syncopal event. They just don't have as good follow-up with these online pharmacies. So this is an example where prevention and protection are potentially hurt by these GLP-1s and how they're currently advertised. Next, let's shift to analysis of recent TikTok trends. This is a descriptive analysis of 100 videos that were posted to TikTok using the hashtag of Ozempic. There were a total of 60 million plus views for these videos, and only 7% of the content posted had any mention of lifestyle modifications. So again, only 7% of videos talked about either dietary changes or exercise in addition to taking these GLP-1s. Most of the videos instead focused on side effects from the medications, how to get these medications, how to manage side effects. And so this is an example where promotion is kind of overlooked by these current advertising models for these GLP-1s. And then finally, I'd be remiss if I didn't talk about this recent trend in compounding pharmacies. This is an advertisement that was on Facebook for Mother's Day, where you could get a discount code to get $50 off your first order of semaglutide that's compounded. Because these medications are so popular right now, the FDA is allowing non-Novo Nordisk pharmacies to produce them themselves. There was an article recently from the Washington Post that looked at this trend and specifically talked about concerns around a Nashville pharmacy. This pharmacy was producing 1,000 prescriptions of GLP-1s per day that they were then sending to patients. They raised concerns about safety for this, lack of supervision, and some medications were being shipped inappropriately to patients. Other direct-to-consumer pharmacies are even being accused of putting non-active form semaglutide in their medications as well. So this is an example where this recent GLP-1 craze is failing to protect patients. So now going back to our case, just as you're about to leave the team room, your attending mentions that, hey, I think this medication may need a prior authorization. How do you think this is going to cost the patient? So now we're going to shift to the final pillar of our quadruple A model, the interaction of direct-to-consumer advertising and cost. There's a very complicated relationship, and so we're not going to go into it in a lot of detail, but there has been a lot of concern about cost and GLP-1s on both the public and private sector. So talking first about Medicare, there's been a significant increase in spending on GLP-1s. In 2018, it was 56 million, and now it's 100-fold more that in 2022. It's important to note that Medicare currently does not approve medications for weight loss, and so any medication for weight loss in a patient who is a Medicare recipient has to be out of pocket or through some secondary insurance. And so you can imagine if these medications were approved to be covered by Medicare, there'd be an even more significant increase. And this is something that's being considered right now, but some are questioning if this price tag is really worth it. And so to understand this better, we can go to the Institute for Clinical and Economic Review cost effectiveness analysis. And I want to specifically point out the quality adjusted life years per life year or quality gained. Semaglutide has a cost of $238,000 and liraglutide has a cost of $485,000. The upper limit of what's considered acceptable from a cost benefit ratio is usually between $100,000 to $150,000. So both of these medications are substantially over these upper bounds. On a more local level, there's also a bill in front of the Colorado legislature right now that would require insurers in Colorado to cover these medications specifically for weight loss. Colorado Medicaid would be one of these insurers, and this is an analysis looking at how much it would cost Colorado each year this bill is approved for the first 3 years. The final year would cost around $250 million for the state. It's important to note that these cost analyses are incomplete. One, there are certain benefits we're not considering into these. So if somebody loses weight on one of these GLP-1s, they have reduced comorbidities in the future and have decreased stigma associated with overweight or obesity. But there are also costs that are not accounted into here as well. Folks may have to visit the emergency room because they're dehydrated, or may be admitted because they have a pancreatitis episode associated with the GLP-1. This is the state level. Even more locally, this is a concern as well. This is an email that just went out recently from the CEO at Denver Health, Lynne. The title was Financial Challenges Force Changes. And the first change she outlined was limiting access to GLP-1s for patients by adding additional prior authorization steps. So now back to our case. You're thinking about this patient as you're walking to the room, and you realize this is going to be a trend that continues. We're ever more connected in our society, and social media is allowing patients unprecedented access to medication and information about it. So now you're asking yourself, how am I going to help stand up for patients in the future? And so for that, I'm going to turn it back to Lynne.
Well, there are a lot of different ways that we could advocate for changes in this arena, but today we're going to focus on some low-hanging fruit. So amongst many other things, we can engage with the burgeoning social media world around us. Fear not, there are many different ways we can do this. Option number one is only for the boldest of us. You can create content and share your knowledge and expertise with the world. Dr. Mike here has up to 4.4 million followers that are all seeing him discuss medical topics and dispelling misinformation. Here in this video, you can hear him talk about Ozempic.
Ozempic, let's stay on that, to lose 5 pounds. How do you feel about that?
It's not what its intended use is. Why that's dangerous is because when a medicine is studied by this evil pharma that we're talking about, it's studied in a certain population, people who have type 2 diabetes, who are overweight or have high blood pressure. So when you're taking it as someone who doesn't have any of these diagnoses and you take it, how do I know that the risks you're facing are going to be what the ones that we found in the research when we didn't test it on people like you? It's the
Ozempic, let's stay on that.
All right. For those of you not quite as right-brained, creating content does not need to be a barrier to entry. Doctors Chopra, Burden, and Lessing often use their platforms to retweet other important work, and each have thousands of followers benefiting from these posts in their feeds. And finally, for those of you who want nothing to do with personal social media at all, we'd urge you to at least look into some accounts that you do trust. Many governmental agencies, including the FDA, the WHO, and the CDC, have accounts that are viewable to the public and often post information about public health topics in non-medical terms. And of course, we couldn't go without giving a shout out to our awesome DOM social media presence. These are all resources you can provide to your patients. We're going to turn it over to Sam one last time to close out our case.
Okay. So you're wrapping up your visit with the patient. You reinforce some key points about GLP-1 agonists and then proceed to recommend some of these reliable accounts, specifically the Twitter for CDC and for Dr. Chopra. You both walk away from this encounter feeling like your relationship is stronger based on this encounter that all stemmed from an advertisement. So let's review our conclusions from today. First, we heard Lynne discuss the history of direct-to-consumer advertising. We learned that despite governmental efforts to protect consumers, regulations have not yet addressed the expansion of direct-to-consumer advertising beyond classic avenues in the digital age. Next, you heard Evan and I discuss how direct-to-consumer advertising differentially impacts all facets of healthcare: the provider experience, the patient experience, population health, and cost. And lastly, we shared our call to action. Rather than shying away from an expansion of direct-to-consumer advertising in the digital age, we urge you as providers to embrace this as an opportunity to advance patient education. Now, we'd like to leave you today with a video from some of our very own physician social media warriors.
Hey, I'm Eddie Stenium. I'm in the Department of Medicine as the Executive Vice Chair. Follow me for medical advice on Twitter and also follow the DU on Instagram.
Hey all, follow Curbsiders Teach on your favorite podcast platform for concise reviews and the latest updates on medical education. And follow CU Internal Med on Instagram for updates on your favorite local residency program.
Hey y'all, follow @TalksTalks for more up-to-date information on opioid adulterants and trends to look out for. Follow me for more information on the best cheap candy in town.
Hey everybody, it's Evan. You should follow the ICU Ed and Toddcast for reviews of some of the most impactful recent literature in critical care. And you should follow me for reviews of cycling around Denver.
Hey y'all, follow NEFJC on Twitter and their associated podcast Freely Filtered to learn about the latest and greatest in nephrology literature. And don't forget to participate in Neph Madness, a bracket-style nephrology educational initiative competition that occurs every March. Follow me to learn about the best ice cream shops in Denver.
Follow me on social media. 50% chance I'll retweet something about cardiology, 50% chance I'll post a picture of my baby.
Hi folks, I recommend that you follow Primary Care Update for patient-oriented evidence that is relevant for primary care doctors, and follow me for tips on gardening.
Hey y'all, if you're interested in medical education or mixed methodologies, follow the podcast Key Lime, Literature in Medical Education on your favorite podcasting platform. If you're interested in being reminded that medicine can be fun too, follow us at cu.internal.medic4 on TikTok for some fun videos of your chiefs and residents.
Okay, and with that, that concludes our presentations. Thank you so much.
Lynn, Sam, Evan, that's the first time we've seen Chiefs dancing, so that was tremendous. Thank you for that incredible talk and that walkthrough for Ozempic. Questions for the crowd to get us going? Yeah, you got one right here.
Thank you so much for such balanced and engaging talk. As you were researching for this talk, wondering whether you came across the lay of the land about direct-to-consumer advertising on diagnostic tests, because we are seeing proliferation of wearables that may diagnose cardiac arrhythmias, images that may diagnose skin cancer, genetic testing that may predict risk of Alzheimer's. And those, as we can imagine, would have lots of downstream consequences. So just wanted to hear what that looks like right now, if you came across that.
There is some certain advertising for diagnostic tests. Not sure about the exact impact, but one example campaign is the Cologuard kind of direct-to-consumer home colorectal cancer screening test. And that's quite popular now. It was parodied in the last year by Saturday Night Live with Woody Harrelson, but don't know about like the specific long-term impacts of that specifically.
Thanks, guys. That was an amazing talk. One comment and then one question. The scenario you described to me is my daily occurrence in clinic, so I appreciate that recognition. One unintended positive that I've seen is patient comfort with injections, because prior to this whole phase, trying to get anybody to do an injection was a huge ask, and now everyone's like, sure, I'll inject myself, because I think they see it, and so I think that's an unintended positive. My question for you guys, have you seen any calls to increase the requirements about information about cost and insurance? You know, I think they say you have to include side effects, but really patients have no idea about cost or how things will be covered. Did you see anything about requiring anything in that realm?
I've not specifically seen anything about costs specifically. I think that's a really good thought, especially with this like GLP-1 stuff. We saw how expensive it is. So I think that's something to consider, because there was one of the epidemiologists from Harvard predicted this could, if like kind of full uptake of these medications could increase US healthcare spending by up to 50%. And so I think it's important considerations. I think one of the things we found in a lot of this research is it was tough because this is just such a new phenomenon that I think the literature is not fully caught up with a lot of this stuff too.
I would say the studies I did see about the physicians' experience with advertisements is that was one of the big things that they felt was lacking in advertisements, the side effects, and then specifically no information on cost.
Thanks. I've got a question about the COVID pandemic. During that time, we saw platforms that hosted Joe Rogan and others that reached billions of people, and many of them had negative impacts on vaccine uptake and use of antiviral drugs. Yet the medical side didn't have any kind of equivalent platforms. Why do you think that is, and what do we need to be thinking about to kind of counter some of those kind of mega platforms that we just can't compete with, Dr. Chopra's Twitter handle, for example?
Yeah, I think in a lot of ways, medicine is playing catch up. Understandably, the pandemic had a lot of different facets to it. And I think social media was not one that people really anticipated. And I think that using social media in the future, sort of what our call to action was at the end, is going to be the best way to combat some of this misinformation, because especially as generations are getting younger, they're turning to social media and TikTok for their news, and so if we aren't on there, then we don't really know who's controlling that news. And so I think folks like Dr. Mike or Dr. Chopra, Sanjay Gupta has a big presence on there. A lot of folks who are starting to get on social media are hopefully going to be able to reach those patients.
I think too, it's an interesting balance to strike, because oftentimes like the Joe Rogan figures, it's a lot of flashy kind of clickbait type stuff. And it's, as a medical provider online, you don't want to fall into that because there's a lot of nuance and kind of details around that. So trying to find a way that's digestible, exciting, but still accurate, I think is a tough balance to strike. And I don't think anyone has found an amazing way to do that all the time.
I have a follow-up question to that, which is, have there been any studies yet of the impact of physicians on social media? Or do you guys have one plan to assess that?
None that I saw. Don't know if either of you came across any of it.
There was an
Great
analysis
idea.
for one of the more looking at the influencer side of things from somebody actually at CU Boulder. And there was some like descriptive interviews with folks that are influencers. And one of the big takeaways there is that they were kind of continually deferring to their providers. Like, you should still make sure you talk to your doctor. So that's kind of one step in that direction, but I don't think there's been specific analysis of physician who are on.
Time for one last question. Dr. Connors.
Hey, that was wonderful. Thank you. What do we know? I love that first map you showed. What do we know about the rest of the world? I can't imagine these companies haven't thought about advertising in London and Paris, et cetera. Is it outright banned everywhere but here in New Zealand? Or why do we not have DTC in the rest of the world?
It's very different for every country. I think the big takeaway is that a lot of countries are still able to do direct-to-consumer advertising for non-prescription meds. So you'll see a lot of over-the-counter meds still advertised there, but it's the prescription medications that they just don't want consumers to be sort of in charge of there. But I think it differs in every country that you go to, probably.
There's been a pretty big shift, right? Because everyone there still has access to social media. So they're still seeing a lot of this stuff. And so it's kind of gone around those traditional regulated kind of barriers.
Well, once again, thank you. And thank you to all the chief residents for their presentations this year. Truly tremendous job. Thank you.